everybody. Welcome to the Evidence-Based Design Journal Club session. Sorry for the slight delay on getting started. My name is Sheila Bosch. I am the Director of Research for Gresham Smith and Partners, and I am the firm-wide resource for our evidence-based design work here. And the Journal Club, as many of you I'm sure know, really is to engage the healthcare design community around a particular article so that we can discuss it and then take the findings and apply them to the greatest extent possible in the work that we do. So thank you so much for joining us. So I am very excited about today's talk. We have a couple of amazing experts on the line here, and I'd like to introduce you to two of the authors of the article that we're discussing. We have Mark Ray. He is the director of the Lighting Research Center and professor of architecture and cognitive sciences at Rensselaer Polytechnic Institute. He is well known for his research in circadian photobiology, mesopic vision, psychological responses to light, lighting engineering, and visual performance. He is the author of more than 250 scientific and technical articles and was the editor-in-chief of the 8th and 9th editions of the IESNA Lighting Handbook. And he has a recent book, Value Metrics for Better Lighting, which brings together a wide variety of research to illustrate how the effective use of light can benefit society as well as the environment. And our second guest today is Mariana Figueroa, and she is the Light and Health Program Director at the Lighting Research Center and professor at Rensselaer Polytechnic Institute. She conducts research on the effects of light on human health, circadian photobiology, and lighting for older adults. She holds a bachelor's in architectural engineering and a master's in lighting and a doctorate in multidisciplinary science. Thank you both for taking time out to join with us today.
Pleasure.
Thank you.
As I mentioned, we are hosting this event to really identify some practical applications of the research. And today's article is Tailored Lighting Intervention Improves Measures of Sleep, Depression, and Agitation in Persons with Alzheimer's Disease and Related Dementia Living in Long-Term Care Facilities. Whew, it's a mouthful. Thank you so much for your work in this area where we really do have limited knowledge in the literature. Today we'll have an active discussion back and forth about the key factors in your study. And I do ask the audience to feel free to pose your questions as you think of them. You don't have to hold on to them till the end. And I'll do my best to get them worked in before our time is up. Let's just jump right in. Tell us a little bit, if you will, why did you focus this effort on people with dementia specifically?
Well, this is actually, we're going to show the work a little bit further in the presentation, but it was based on work that was done in the late 90s. We do know that Alzheimer's disease patients, they have sleep problems. They're as likely to be awake as they are to be asleep. They don't have a consolidated sleep period, and this is one of the main reasons why they are institutionalized. And there has been earlier studies showing that high levels of light can help improve the sleep and consolidate sleep during the nighttime. So what we were interested in, can we have a more tailored lighting intervention so that we don't have to have such high light levels, and that's what we're going to be discussing today.
Okay. Before we begin, I just want to acknowledge our co-authors on this paper. Barbara Plitnick, Anna Locke, and Jeff Jones are here at the Lighting Research Center. We have two colleagues at Case Western in Cleveland, Patricia Higgins and Tom Hornick. So we're all part of this project, so we're pleased to present that today. So the thing that I think we wanted to come to grips with, as Mariana just said, is that sleep and falls are the two major issues facing seniors in living facilities. One of the things that I think that we try to avoid at an interdisciplinary center like ours is sort of work on one single problem. So what we're trying to do is deal with a comprehensive look at how do I deal with the visual environment, how do we deal with the visual environment for seniors. So we need to look at both the visual and non-visual systems. In principle, you can improve one and hurt the other, so you always have to remember that you have two systems that are at work here for a satisfactory living environment. And the way we frame these problems is what we call input-output relationships. If you know the stimulus, you know what is driving the visual system or the circadian system, you have a much better chance of predicting the output. And the output, again, is to improve sleep and reduce falls. So in that context, this is a unique population because they're in this building usually 24 hours a day, unlike you and me, which might go out for lunch or go home from work and so on. These people are really constrained to this one environment, and therefore gives us an opportunity to really address it as a 24-hour lighting scheme instead of just a patchwork of individual problems. So let's do the background. I'm going to concentrate on the background, then Dr. Figueroa is going to talk more about the applications.
And keep in mind that most of us on the call are not lighting experts, so I won't say dumb it down for us, but...
Well, I only became a lighting expert a couple weeks ago, so I'll try to make this clear. So, again, what we're going to do is truly talk about the visual system and the circadian system. And, again, I'm going to give the background here as best I can. So this blue diagram with arrows shows the input-output relationship. To predict how well someone sees, you need to know how big the target is, how much contrast or its distinctness against the background, and then how much absolute light level is actually reaching the eye. And we use what's referred to, and I apologize for using a jargon term, the photopic luminous efficiency function, which is in the lower left-hand corner. But this tells you how the visual system translates electromagnetic radiation, and it has this bell-shaped curve that represents a maximum sensitivity to the peak and then tails off. Once you've specified the stimulus, once you know what that is the size, the contrast, and the luminance, you can make predictions of performance, which are the four panels that you see on the right. And those represent the speed and accuracy with which people can process visual information as a function of those three variables. The four panels are for different sizes shown by the acuity chart icons they're associated with. The goal, without getting into details, the goal is to get everybody on the plateau of this visual performance. And you'll see that it's pretty flat. Once you get up there, you have a lot of latitude with contrast and size and light level, but you've got to get up above that escarpment, and that's really the goal in the lighting design, and that's what we're trying to achieve.
What are some of the practical design considerations as it relates to this here?
I think that a lot of people think you just put more light in and it's going to be fine, but often a bucket of paint is the most effective thing you can do. So if you can make hazards more distinct by highlighting them in high contrast, for example, you reduce significantly the chances of falling off that escarpment that we're talking about, particularly for older eyes. And you'll see here in this next slide that on the x-axis you have age in years from 20 to 60, and on the y-axis you show how much light actually gets transmitted relative to a 20-year-old by the time you're 60. So by 60 years of age, only about one-third of the light is actually reaching the retina. And you can see in the panels on the right progressive reductions in the transmission from, in this case, a very young to a 90-year-old subject. But it also reduces contrast, and that's why that bucket of paint is so important. So yes, light level matters. Try not to put things in shadow so that they can't see it, but really increasing those hazards like stairs and door frames and so on where someone might trip and fall. That's really a key design element.
So that color contrast is really important as well as...
Contrast is probably the most important thing you can attend to from a design aspect. Get the contrast up, and it may look odd, but at least the people with impaired vision can see it quite well. Now, we've produced what we call a relative visual performance calculator, and that's, again, predicting, if you will, the visibility as a function of these parameters: size, contrast, light level, and age. And this just shows you a couple panels of the output. If anybody would like that, we'd be happy to send it to you at no cost. Just send us an email, and I'm sure that we'd be happy to send that to you. Now, the real concept that we want to sort of emphasize today is circadian rhythms. Light coming into the eye, not at the top of your head or on your ankle, is what drives circadian rhythms in all species, plants and animals. It's the light-dark pattern that really entrains us to our local position on Earth. So if we move to Australia, that system has to resynchronize to the light-dark pattern in Australia if you leave New York or California. And these circadian rhythms, then, I think it's a bold statement, but I'll make it anyway. I think these rhythms are the platform for all biology, and they are so central to things like sleep, health and well-being, and performance that I think these are the things that we're seeing the science emerging now quite powerfully. Now, our metaphor for this is the two girls in the swing here. The girl on the left is to represent the light-dark cycle, sunrise and sunset. Every 24 hours, the sun comes up and then comes up again another 24 hours later. We have a biological clock connected directly to the eyes that has an intrinsic period of 24.2 hours. Now, you notice that the light-dark cycle is 24, but in diurnal species, we tend to have a clock that runs a little longer than 24 hours. And that's represented by the girl in the swing. So without the girl pushing back and forth every 24 hours, she would naturally swing at a rate of slightly longer than a day. So the girl on the left is the one that regulates where you're going to have your peaks and trough in those circadian rhythms. And I want to say that light-dark cycle is the most important thing for driving that clock. Exercise, diet, and so on are really less important in that consideration. Now, if you imagine our evolutionary background, everything was good when all you had was sunrise and sunset. But electric lighting has introduced the capabilities of maintaining us in perpetual darkness. We can still see, but the circadian system may not see that light-dark pattern, or light at the wrong times can disrupt that swinging. So it would be like that girl on the left pushing at the wrong time and disrupting the rhythm. And if you disrupt the rhythm, there are dramatic biological consequences: poor sleep, digestion, lack of performance, and so on. So here's our friend that we saw before, where we had the photopic luminous efficiency function. What's very interesting scientifically is that the spectral sensitivity of the circadian system is shifted to short wavelengths. We refer to it as a blue sky detector. Our circadian rhythms, it's the same eyes, but they have a different response to radiation on the eye. So this is to show you, and I won't go into the details, but it shows you that the shift is to very short wavelengths. So blue light is much more powerful than, say, red or yellow light to driving the circadian system. Now here's the absolute sensitivity, and I hope you can see this without me going through the cursor, but on the far left is this dark bar, and that's really what we're exposed to for outdoor lighting. The next the lighter gray then is indoor lighting, and then the faintest gray is indoor lighting, and then the white area is for outdoors. So those of us that had an agrarian life 200 years ago were always in that white region. We were getting a very strong stimulus. But if, for example, like Alzheimer's, you're indoors all day, you're getting very marginal stimulation by light. Even though you can see fine, you still do not have the light for the light-dark cycle, which is important. And so quantifying that information and then design characteristic becomes really important, because we're all used to designing, if you will, for visual, but now this new field of designing for circadian, I think, is the one that we'll see emerging more and more in lighting specifications in the future. So like we had a calculator for visual performance, we also have a calculator for determining how effective different light spectra, whether you have a fluorescent lamp or daylight or incandescent, and at what level. This particular graph shows the weighting function of the circadian system, but that's a daylight spectrum. So we can calculate how much daylight you need into a space to actually drive the circadian system. Now, all of that has been integrated into a device we've been evolving over the last few years, which we call the daysimeter. Europeans often call it a daisy-meter, which is okay. We can respond to either name. But you see the evolution. What we're trying to do is measure light at the eye, that's the input, And then what we do is we also have built-in accelerometers. So your smartphone has an accelerometer in it, for example, to do things like pedometry and so on. We have that built into the system as well. So these are the earlier versions, and the latest versions are the ones that you see here. And we're using those in a wide variety of applications, not just with Alzheimer's, but with submariners. We've even put some on lemurs in collaboration with Duke University. So this is a very powerful tool of trying to get the light as the input and then measuring the output in terms of activity. That's what we measure as the input-output. And here's a chart from a study we did with the Nurses' Health Study to be able to look at the input-output relationship from the data we gathered. So the top trace is 7 days of recording light exposure at the eye and how active this particular day shift nurse was. And you can see just qualitatively that there's a high correlation. When there's light, she's active and so on. But down below is a rotating shift nurse, and you see that it looks much less regular. What you see is the input occurs at irregular times, not every 24 hours, because remember, she's working the night shift occasionally, and then the activity. So you can see here she sometimes takes naps. There's a wide difference between day-to-day operation, if you will, for a rotating shift nurse and a day shift nurse. Now, if you look at the population we have, what you see is, first of all, the day shift nurses do get more light on average than a rotating shift nurse. So the blue ones represent all of the nurses, the day shift nurses in our study, and the red ones, all of the rotating shift. But you'll notice such a large overlap. There's although there is a statistically significant difference, just because you're a day shift nurse doesn't mean you necessarily have more light than a rotating shift nurse.
There are a lot of other health risks, aren't there, to being a rotating shift nurse as well?
No, that's a great question. I should have mentioned it. What we've seen, others have seen in a number of epidemiological studies, is that the incidence, for example, in breast cancer can be a factor of 2 greater than it would be for a day shift nurse. The hypothesis is that disrupting that circadian rhythm has led to a potential causative problem with regard to the health outcomes. And again, it isn't just breast cancer, not only sleep and performance, but things like cardiovascular disease, diabetes, and so on. So this disruption really is important, and rotating shift nurses seem to be among the worst of the ones that are affected by this. The other group of things will be flight attendants, for example, that do transoceanic flights. But the bottom line shows that the activity doesn't really differ. There is no difference, but again, a wide spread. Now, what we came to realize that it wasn't just light by itself or just activity by itself. What we're interested in circadian rhythms, whether you're a plant or an owl or a fungus or a human, it is the synchrony between the input and output that we want to measure. So bear with me. I'm going to try to explain this as best I can. I won't get into the math, but what you see is the same data for a day shift nurse. The blue traces are 7 days of light exposure. The red traces are 7 days of activity. Now, what we're going to do is sort of a mnemonic device is to tape those strip charts on the circumferences of these two discs, a red one and a blue one. And then we're going to rotate them, and we're going to calculate the correlation between light-dark and rest activity over the period of time that we collected data. And the panel at the right will show you how those correlations vary. And what you see is a very smooth, consistent, regular pattern of light and dark, activity, rest, as if they're coupled together. So when you have a high correlation, the rest activity is in phase. When you have a low correlation, they're 180 degrees out of phase. But what we can do is do a set of math that allows us to look at the period, the 24-hour period, which is what a circadian rhythm should be, and we can put a sine wave on it, basically, to extract the amplitude, how high is that, and what the phase relationship is. And from that, we derive these vectors, which we call phasors. And that phasor represents a typical day shift nurse phasor. And what it is a measure of the coupling between input and output. The longer the phasor, the greater the coupling. This particular one shows a coupling about 0.5, which is about maximum that we've seen for day shift, teachers, kids going to school, not people on submarines, and not people that are doing rotating shift. Now, we can do that same analysis now with the data from the rotating shift nurse. We cut out our strip charts, tape them onto these two discs, rotate them, and what you see is a more irregular pattern. That says qualitatively that the coupling between the input and output is not as strong as it was for the day shift, but we apply the same math where we fit the best 24-hour cycle to it, calculate a phase and amplitude, and now plot those together. So what you see is a much shorter vector, a much shorter phaser for the rotating shift, which says they're not very well entrained. They have circadian disruption. The angle then also tells you how their behavior is with respect to light. So when it's in the position that it is for the disrupted rotating shift nurse, that means that they're active during darkness, whereas the one for the day shift nurse means they're primarily active during the daytime, as you would expect from a diurnal species like the humans. Now, we come to the older adults, and I think it's very interesting when you begin to make field measurements of this is a 67-year-old. He has a phaser of about 0.45, which is as good as a lot of the young people we've seen. This person is also living at home, doing normal activities, and really from a phaser analysis or circadian entrainment doing well as those day shift nurses. But you notice there is no phaser vector for an Alzheimer's. Their activity pattern, their light-dark patterns are all more or less random and therefore have no coupling between the light-dark pattern and the rest activity or input-output relationship. What Dr. Figueroa is going to talk about is how do we make an intervention that improves that pattern. Now, we're not going to cure Alzheimer's, obviously, but what we can do is we can help them with better sleep, better outcomes, and so on. Whoops, sorry, I went the wrong way.
Hopefully avoid the institutionalization earlier in the progression of the disease, right?
Yes, because we don't have typically, in the name of energy efficiency and low-cost lighting, we don't have a regular light-dark pattern. And what we're struggling with is how do you get that to them because we can show positive outcomes. So to summarize my piece, age-related changes in the eye reduce luminance and contrast. Contrast is very important. As I say, paint can sometimes be more effective than increasing lighting. And by that I mean anything that increases contrast that we need to do to improve visibility, to reduce falls in particular. Design alternatives can be compared with the calculator, so you can see what the magnitude of the proposed intervention might be. What if I made it bigger? What if I made it more contrast? What would be the impact, and should I do that from a cost-benefit analysis? The 24-hour light-dark pattern is what drives biology, and it doesn't matter what species you're talking about on the surface of the Earth. We are a 24-hour species, as is every plant and animal. If you expose people to irregular patterns, like put them on Mars, which is not a 24-hour pattern, you're going to get disruption that has health consequences. The circadian system is a blue sky detector. It has a high threshold, so even though you can see reasonably well, does not mean you have sufficient light to stimulate the light-dark cycle that needs to do circadian entrainment. But again, what we can do is we can measure the amount of light and we can measure entrainment in the field. And these two tools, I think, are the ones that really begin to help the specification get past the good intentions of the design and begin to engineer something tangible and effective. So I'll turn this over to Dr. Figueroa now, and she'll talk about the application.
You might have questions.
Oh, do I have a question?
There was a question that came in from Cheryl Brown asking whether there are also increased health risks with people who travel a lot, say, adjusting to a time zone on the other side of the world if they're maybe traveling every other month to these, various regions. Is there any literature on that you're aware of?
Yes, flight attendants are among the most vulnerable with regard to circadian disruption and consequent health outcomes, heart disease, obesity, breast cancer. Those are the things that are closely tied to disrupting that circadian system, and that's actually probably worse than even a rotating shift nurse. Now, just as an aside, we put mice we fly them back and forth to China every couple of days, and they're not very healthy mice. So these are, we don't literally fly them to China, but we can fly the light-dark cycle to emulate that. And yes, it's extremely disruptive, not just for sleep, fatigue, and performance, but the health outcomes are really also compromised.
Somehow I love that visual of actually flying mice to China every couple of days.
Yeah, that's part of the fun of doing research. We can do these things. Okay, I will follow from the background remark, and I think the question that we were trying to answer, and we talked a little bit about that in the beginning, is can light help? And that's really a study that was done in 1997, was published by Joos van Summering. He is in the Netherlands, and I think this is a beautiful study. I'll walk you through these graphs. What that is, if you look at the bar charts, it's really wrist actigraphy. So it's measuring how much activity you move with the wrist. And what he did is he collected baseline with the normal lighting that Alzheimer's patients were exposed to, and then he measured their activity. And if you look at the far right of the graph, these patients were sleeping during baseline only between 2 and 5 o'clock in the morning. He then exposed them for 4 weeks to about 1,100 lux at the eye, which is a lot of light. It's really, you need to be near a window, or you need to increase a lot the amount of light in the space to achieve that. And what he saw after 4 weeks, that the rest activity patterns, they were much more consolidated, and they were sleeping by about 10 p.m. till about 6 a.m. So they increased and consolidated their sleep. Then he removed the light, and what he saw was, again, a messed up sleep-wake pattern, and they were only sleeping for a few hours a night. And as we mentioned, this is one of the main reasons why Alzheimer's disease patients are institutionalized. The only problem is that achieving 1,000 or 1,100 lux at the eye is very difficult because you have a lot of energy consumption. It can be glary. It can be impractical to implement. So what we were interested, and that's really what the study was using a circadian tailored lighting intervention. So what we did is we used aquarium lamps. These were actually GE lamps that you can buy to use in your aquarium. And we built these fixtures. We put about 400 lux at eye level. So we dropped the light levels by 3 times, basically from what Van Summering used, because we were using more bluish-white light sources. So the color of the light looked more bluish. There was more blue light in it, which means it was more effective for the circadian system. So that really was the tailored part of the intervention that we were giving.
We have a couple of questions I want to get before we move on. One is, can you explain the different lighting descriptors, lux, color, temperature, wavelength, and how that really relates to this study that you've conducted?
Yeah, well, lux levels, if you buy a light meter, it's really how much light is reaching a surface. And it uses, I don't know if you'll remember, I should do that as the quiz, but if you remember what Mark said as the photopic luminance efficiency function, it's really looking at 2 out of your 3 cone photoreceptors and how they respond to light. Okay, so if you buy a light meter, it will give you lux levels. What you typically have in your office is about 200 lux at the eye. So what we used in the study was about twice as much of what you normally have in an office space without a lot of daylight. So that gives you a ballpark. If you're outdoors, you can have from 5,000 to 10,000 lux on a cloudy day to even as much as 100,000 lux on a sunny day. So that gives you sort of ballpark. At home, in your kitchen, you probably have about 50 lux. Okay? In terms of color temperature, an incandescent lamp that looks yellowish white is about a 2800 K or Kelvin temperature. As you increase Kelvin temperature, you increase the amount of blue light, or the color of blue is going to look more bluish white because you tend to have more short wavelengths, okay? So a 6500 K or a 9000 K, which is what we use, is going to look more bluish white. And there's going to be more energy in the short wavelength or the blue part of the spectrum. Okay.
We have one more question, too, that just asking about what field instruments do you use to measure circadian entrainment and disruption?
What was the instrument that we used?
That was the day.
We used the dosimeter that was that funky that we started with the eyes and we ended up using as a pendant for the Alzheimer's patients. So we're using it as pendant or sometimes on the wrist. It depends on how the patient would accept it. And the dosimeter it collects red, green, and blue, RGB, and then from that we can do a post-processing and we can calculate lux levels and we can calculate circadian stimulus. And then we also have actigraphy on it. So using the actigraphy and the light data, we can calculate that phasor that Mark explained. Yeah?
Right. Thank
okay.
You.
All right. So for the study, we recruited 19 subjects. We had 14 subjects who completed the study. Unfortunately, being able to keep the subjects in a 4-week study is a challenge because it's hard for them to sometimes complete the study, but we were able to complete and have complete data for 14 subjects. We collected actigraphy, which is the same device as Ben summary. In our case, the actigraphy we used was the actigraphy from the dosimeter. So we used the dosimeter on their wrist, and we were measuring light and actigraphy in the wrist. I have to say it's not an ideal way of doing it because on the wrist it can get covered a lot, but with this population, that was the best compliance that we got in terms of the instruments. With those data, we calculated sleep duration and sleep efficiency. We also looked at how much circadian light they were being exposed to, and we did the phasor analysis, which Mark explained. And then we collected some standardized questionnaires that was probing their sleep quality, depression, and agitation. So we looked at the Pittsburgh Sleepiness Quality Index, the Cornell Scale for Depression and Dementia, and the Cohen-Mansfield Aggression Index, or CMI.
And did you take parts of those different tools and combine them into a tool, or did you give all of them in their entirety, and was there any, survey fatigue from completing that you know of?
No, we had it all in their entirety. What we did with the surveys is we came, again, on a baseline. That's what this slide is. We had a baseline data collection, so we collected those questionnaires during baseline. We typically, because these patients cannot answer these questionnaires, we had the caregiver as proxy to answer for these questions. We then did the 4 weeks of the lighting intervention. So after we collected baseline data for a week of dosimeter data, plus at the end of the week we collected the questionnaire data, we installed the lighting in their bedroom. So basically those light fixtures you saw a couple of slides ago, we just put them inside their bedrooms. And we left them on from the time they woke up until 6 p.m. It was on a timer. And it was unattended. So if they were in their rooms, they were getting the lighting. If they were not getting the lighting. But we just left them on. At all times, there was a vacancy sensor, so if nobody was in the room, it would be turned off to save energy. And then on the third to fourth week, we collected the post-intervention data. So basically we came back, we collected again 1 week of dosimeter data, plus the questionnaires again to see what the change was from baseline to intervention. And then we removed the lighting intervention, and after 4 weeks of a washout period, we came back and we collected data again, and the expectation was that they were going to start getting back to becoming worse again if there was any improvement with the lighting intervention.
Now, this lighting situation you've created in their rooms, is that something that could easily be incorporated into a typical light fixture? I know you said you use the aquarium lamp, but how difficult would it be to adapt to typical?
Well, it is interesting. When we did the study, it wasn't that easy, and I think manufacturers are now starting to come up with new products that are becoming readily available for this kind of application. With LEDs, you can now change the color, you can change the intensity very easily within the same fixture. So we're seeing more and more options for that to be implemented in real life. So in general, what we found in terms of the findings is we saw that the lighting intervention significantly reduced their agitation scores, so they were less agitated with the lighting. They were less depressed with the lighting. They increased the amount of sleep after the lighting intervention, so they were sleeping more, and they had a greater sleep efficiency after the lighting intervention. Their sleep efficiency, which means is that they were spending more time asleep during the time that they were in bed. The sleep efficiency increased from 80 to 84%. And just to give you an idea of what the clinically relevance of that could be, is there was a study showing that if you have an increase in sleep efficiency from 80 to 84%, you can actually reduce the amount of deposition of beta amyloid. And beta amyloid in the brain is what's been associated with increased risk of Alzheimer's disease. So if you have less deposition, you are likely to be at less risk for developing the disease. Now, I'm not saying that lighting cures Alzheimer's, but I think that it's important to bring it into a clinical context and see how important that would be. All right, so there are obviously limitations of the study. We did not use a placebo lighting, so it would be changing the lighting in the room but giving a lighting that is ineffective. And we're actually funded now to do that, so that's what we're currently doing, is collecting new data to look at that. We did only a 4-week study. We want to know what happens in a long-term study, so after 6 months, do we continue to see those improvements? We obviously need to demonstrate that in larger sample size. I mentioned about the wrist dosimeter being covered sometimes, and the subjects didn't always stay in their rooms, so we don't really, even though we measured how much light they were exposed to with the dosimeter, it's hard to know over the course of 4 weeks if they really got all the light. But given that they don't have a lot of things to do, staying in their rooms is something very common for this population. So just putting it into, I'm sorry.
Are you planning to also do the lighting intervention in the activity rooms or some of the other areas as well?
Yeah, this is a great question. Yes. What I think, what we're now planning on doing is expanding to other areas in the facilities. But I think the ideal, and that's where I think designers need to be listening very carefully, is the entire facility needs to be designed so that wherever the patient is receiving that high circadian stimulation during the day. So that becomes a whole facility solution rather than just one solution for one bedroom, for example. And that's really what we hope is going to happen in the future. So what we've been trying to sort of put forward is, again, this 24-hour lighting solution. And one part of the solution is this high circadian stimulation throughout the facility. But also, as Mark mentioned, you need to think about the visual system, and you also need to think about another problem in assisted living facilities and nursing homes, which is falls. So we've been proposing this 24-hour lighting scheme, which would be good visual stimulation, good day-night signal to promote circadian entrainment, and safe night lights that could reduce falls. So I'll go through each of those quickly. So one of them would be for the visual system. As Mark mentioned, we get about a third the amount of light in the back of the eye when we're 60 years old compared to when we're 20 years old. So we need more light to be able to see tasks or to be able to see small details. We are more sensitive to glare, so whatever we do, we need to minimize glare and minimize direct or reflected view of the light source. We want softer shadows in the space. We are very sensitive as we get older to very sort of patches of light and dark. We want to have as much as softer lighting in the space. And to Mark's point, a bucket of paint is great because if you increase the white colors or the light colors in the surfaces and you have indirect lighting, you increase that softness of the shadows in the spaces. And as Mark mentioned, increase contrast and improve color discrimination. So there's a lot you can do in addition to lighting to improve visibility. So here are just some visual techniques, some techniques for the visual system. One thing that people tend to forget a lot is shower lights. They are very important. And once you have one, you cannot live without. I speak for myself. It's just amazing that people don't even think about that. Uplight ceilings and washed walls. So again, get lighting into the environment through reflecting off of surfaces, of light color surfaces. Use task lights. Where do you know that they're going to be using a knife or they're going to be threading a needle? Plan on having task lights in these spaces. For the circadian system, this is an area that it's still a lot of under debate of what to do, and what we're using here is, to the best of our knowledge, this is what we think will have an effect, and it is to give people at least for 2 hours in the morning or all day a circadian stimulus of at least 0.3 to 0.4. And that is roughly about 175 to 300 lux. So again, it's slightly higher than what you get in your office, of a 6500K lamp, which is a bluish-white light source. Another alternative is use blue light, literally blue color light, a 470 nanometer light. And then you can reduce the amount of light. So light boxes, there are light boxes available in the market that use this kind of light. Promote outdoor activities, bring daylighting into the space. That will guarantee that you're going to get good circadian stimulation. Daylighting is an ideal light source for the circadian system. Now, circadian system cares about contrast. You need high amounts of circadian stimulation during the day, but you need to drop that in the evening. So use something less than 50 lux at the eye of a warm yellowish white color, like an incandescent light source. So make sure that the light levels are dropped during the evening hours. Mark mentioned the Circadian Calculator, and we have it available. If anybody's interested, get in touch with us. We can give you that. So here are just ways that you can implement some of these techniques. You have more bluish daylight light sources during the day. You reduce to warmer colors, lower light levels during the evening hours. You can also do things like luminance panels. We've been very successful with creating a light table. We have a TV where we made that a light table, and people are sitting and having meals around it, and at the same time they're getting light. So be creative in how you're going to deliver that light. It doesn't necessarily have to be just ambient lighting. The other way is, this is the blue light that I mentioned, so these are blue light goggles that can be built to deliver that light if a patient can wear this. And like I said, you do want to remove, in these orange-tinted glasses, what they do is they will remove the blue light. So a combination of the giving light during the day and removing light during the evening becomes very practical. Now, we are also working with healthy older adults in delivering light through a light mask. So while people are asleep, we're giving the light through closed eyelids. And that has been very effective as well. So there are creative ways to doing it, but I think for Alzheimer's patients, one of the things that I've learned with my experience working with them, none of the individual light treatment devices are going to work. You need to really think about the ambient and how you do that. Finally, for safe night lights, we are working with the idea of giving these horizontal vertical lights, and you can place that as night lights around, say, door frames in bathrooms, on occupancy sensors and photo sensors, so that when a person gets out of bed, that light turns on and it gives them these horizontal vertical cues, the same way with horizontal cues when they walk. And this helps them with improved postural control and stability. And this is just how you could install some of these techniques. We have people in Australia that are installing that in hospital wards to minimize falls in those who are in hospital wards. So there's applications beyond assisted living facilities. So I think just the final message is that you can improve sleep behavior and mood in Alzheimer's disease patients. The science behind it is very solid, and it may be clinically relevant. Consider implementing this 24-hour lighting scheme where it's not just about circadian, but it's improving visibility as well as helping minimize falls risk. And our message is, let's just do it. I think that there's a lot of talk about, well, we don't know enough, or we're going to be doing harm. I think we're doing harm by not doing anything and by leaving Alzheimer's patients in very dim facilities, constant light, which is just not good for them. So I think there's lighting solutions that we can adopt now that we can improve the health and well-being in this population. So with that.
And you made me think, when you mentioned about, get outdoors, it made me think about, particularly in long-term care facilities, the importance of creating outdoor spaces, whether it's a garden or some other kind of space that has, that has shading and protection from the elements, but is easily accessible by wheelchair and walker users and that sort of thing as well. So
that's correct. I mean, if you can have skylights, or if you can have outdoors, I mean, obviously now we're here in the Northeast, with snow and temperatures below zero, you can't go outside, but if you can create an environment that they can get that daylight, this can be part of the design. If you have a chance to start the design, think about that when you're doing the design.
This is really a great study, and thank you both so much. I'm just curious, so do you have other populations? You mentioned you are doing work with healthy adults as well. Are there other populations that you plan to target?
We have worked with teenagers, trying to get teenagers to go to bed earlier so that they can have an 8-hour sleep night instead of going to bed at 1 o'clock in the morning. So part of what we're looking at is how even playing with iPads and iPhones and all these devices can affect them. We're working with Dr. Robert White in South Bend, Indiana, looking at a lighting system for premature infants to put it on top of incubators. So we're really going from premature infants all the way to the aging population because lighting does cut across all these different populations. So we are working with lemurs, and we're also working with the U.S. Navy with submariners, and we're changing the lighting inside submarines and doing some studies with that. Navy SEALs, that was a popular study here in the lab. Everybody wanted to come see them. So it's been a very interesting area of investigation.
So it sounds like you all are never bored.
Oh no, there's no such thing here. We're always illuminated by the lighting, right?
Right. We did have a couple of other questions, and those of you who have questions, feel free to send them in now. I did want to, let's see, let me scroll up a little bit here to see a couple of the questions that I did not get to yet. And one is, for color contrast, what colors, or combinations of colors, I guess, do create the best contrast? And ADA has certain, I guess, standards which are implemented, like yellows, whites, blacks. What recommendation would you give for improving contrast?
The greatest contrast you can have is black on white. Yellow is a more desaturated color, so you wouldn't want to have yellow and white because that wouldn't have much contrast to it. But yellow and black, as they do in the chevrons for curves on the road and things like that, are also very effective. The color issue probably conveys other types of information which I didn't talk about, like red meaning danger, yellow meaning caution, and so on. So I'm not quite sure how that all gets integrated into the design process. But I think that you can have instruments that actually physically measure the contrast, and that's really irrespective of the particular hue, whether it's yellow or pink or blue or whatever. It's the distinctness that is really important. And again, the most contrast you can ever get is black on white.
Okay, thanks. We have another question. Have you studied or are you aware of research that exists regarding the effects of lighting on mental health patients? Good question.
Yes, there is. There's obviously a lot of work being done with seasonal depression, and light is actually a recognized treatment for seasonal depression. So if somebody's diagnosed with seasonal depression, some insurance companies will actually pay for light boxes. So that's a very well known. But we also are working with veterans that suffer from post-traumatic stress disorder or PTSD. So they have a lot of sleep issues, and we're starting to look at lighting as a non-pharmacological intervention, as well as mothers with postpartum depression. So we have a pilot study going, collecting some data, seeing if mothers who tend to suffer from postpartum depression would respond well, because it's good to have non-pharmacological intervention for this population. So those were the areas that we've been working with. And we did see an effect in depression in our own patients with Alzheimer's disease, and that was even stronger in winter months, which makes sense.
Sure. Let's see, another question regarding the question is, how does softening shadows and balancing light fit within the desire to establish both color and contrast and color discrimination?
Well, I think that probably the worst case scenario that I can imagine is diffuse illumination with pastel colors. That's like us walking in the fog. Now, I believe that it's better to address the materials in the space, if you're, the hazardous ones in particular, draw attention to them so that people with low vision can see it. In principle, you can do the same thing with lighting by creating shadows. The downside is that whenever you have a shadow, you have a dark area. So I think that the combination of more diffuse, not completely diffuse lighting, matched with materials in the space to provide contrast, particularly for those areas that might have trips and falls, is really what we need to be concerned with. But Dr. Figueroa also showed the framing of the door with LEDs. It doesn't just have to be paint. You can do that with light, and that also provides a great night light as well. So again, high contrast at those critical places, whether you do it with light itself or whether you do it with reflective paint. That's really what you need to do. What I'm afraid of is when people have these very strong directional lights in these spaces, they create shadows, and if somebody left something on the floor, for example, that's a hazard that would not necessarily be seen.
We have a lot of good questions. We might not be able to get to all of them, but I want to do at least one more, and this is are you aware of research regarding the effects of the lights that you can change the color? Any effect on nursing staff specifically?
Yeah, we in this particular study, we did not look at the nursing staff, mainly because we were doing it during the daytime, and most of the studies looking at nursing staff, even though there's some recent studies looking at daytime lighting, most of it looks at nighttime. That's the time when you're most tired, and light has been shown to increase alertness and certain types of performance from shift workers. We have been doing some work where we're looking at red light as an alerting stimulus, and the advantage of red light, it doesn't suppress the hormone melatonin. We do know that suppressing the hormone melatonin at night has been linked to breast cancer risk in rotating shift workers. So I think that there's a potential, and when we do lighting for these kinds of environments, we need to think about the nursing staff as well. So we could use certain types of lighting for improving nursing staff, and we could probably do a whole other journal club on that to talk about what are the lighting solutions for nursing staff. And I think they are different, but they can sort of come together between the patient and the nursing staff.
You know, I think I'm going to go, since we started a little late, I think we can go a couple of minutes extra as well. We have 2 or 3 more questions at least, so I'd like to address them if we can.
Sure.
So the next question is, so a 9,000 K light source is much cooler or bluer than typically used indoors. Would you anticipate pushback from an aesthetics perspective on using such a cool light source throughout the facility?
Well, I think there's sort of 2 answers to that question. I think that immediately people may react to it, but 9,000 K is not different than what you get outdoors, so people seem quite happy with that. But you don't expect such a cool light source for electric lighting. So I think people can get used to it, as long as it doesn't distort colors and has, you know, other sort of collateral problems. But I don't think you'd want to use a light source like that in the evening when we're trying to get the color temperature to 2700 K, still be a white light source, and lower light levels. So I think the question has to be what time of day. I think in the morning in a school or a hospital might be perfectly fine, and might be a little unusual to begin with, but if you explain to people, you know, what you're trying to do and so on, I think people could embrace that.
And I have to say from our study, we had absolutely no complaint. And again, because you may mix it up with daylight, and nobody said, I can't stand this light, or there was no complaint. And
they did notice it though. We
were not mixing the low CCT with the high CCT. That's another important point. Don't mix the two, because then they look much more bluish. People will somewhat adapt to that bluish light if they are in the environment for some time.
Yeah, again.
Go ahead.
Sorry? I was just going to say that nearly everybody notices it, But they did seem to get used to it. But I think Mariana's a good point, is that if you mix it with an incandescent light bulb, it's even more prominent and could flag a problem you wouldn't necessarily have if it was the only light source in the space.
There isn't really evidence that it is more irritating, for example.
No, but I do have to say that there are reports in the literature that some Alzheimer's disease patients do get more agitated, not with the color of light, but with the higher intensity of light. So there is a chance that some patients would react the opposite, which is they would get more agitated. We did not have that in the study, but I have seen reports in the literature that it can happen.
I want to say, too, that these light sources that produce these very cool color temperatures tend to be a particular technology. And so problems you might get with the technology are not necessarily due to the color temperature. They have to do with whether it flickers or not, or some of the other issues that you need to be. So just because it's 9,000 doesn't mean it is or it isn't. You have to know what the other characteristics of the light source are. Like I say, for daylight, most people like it. But they might not like it as a flickering fluorescent light, for example.
Right. Well, we have one more question, and that is, your intervention that you did here, did it have any impact on the sunset effect? And could you describe what that is as well, sunsetting?
Yeah, this is something very common with Alzheimer's disease patients, and they tend to get very agitated starting late afternoon, early evening. That's why they call it sundowning or sunset effect. This is very typical of the disease. We did not specifically look at how the lighting intervention affected that, because our patients didn't have that as much, even though general agitation was reduced. But there has been some report in the literature that they do have less of the sundowning effect if they have that light exposure that entrains their circadian rhythms. But this is, again, it's still something that is under investigation. We see reports both ways. So,
thank you both so much. This has been such a pleasure. I'm going to go ahead and wrap up now, but we just really appreciate you sharing all of this with us today. It was a very thoughtful look at the lighting interventions for persons with Alzheimer's. One final reminder, if you would like to earn CEUs for this session, download the form found in the media library. For credit with the AIA, you will need to purchase a CEU management fee for $10 and complete the CEU verification form and quiz and email it to Shannon Reckline. I do hope all of you can join us for our next EBD Journal Club. That will be on April the 8th. 1 o'clock Eastern, and I will have a discussion with Lori Wolf and Eileen Constantino on the article titled Fall Prevention for Inpatient Oncology Using Lean and Rapid Improvement Event Techniques. Just like to remind you that this event is brought to you by the Center for Health Design's Research Coalition and the EDAC program, Evidence-Based Design Accreditation and Certification. And I would like to thank the HERD Journal. They typically provide us access to the articles that we use here for free. Today was not from HERD, but if you haven't subscribed to HERD, I really suggest that you check into that. It's an amazing publication. And your feedback is really important, so if you can take a moment to complete a quick survey at the link at the bottom of this slide, that would be fabulous. This concludes our event, and thank you all for joining us. Have a great day.
Thank you.